Hello, everyone. Thank you for joining today's webinar. We're still waiting for colleagues to join us. We will start shortly, but thank you for coming early. Hello, everyone. Thank you for joining today's webinar. We are seeing more and more participants joining in, so thank you so much. We're still waiting for a few more colleagues to join us, so stay tuned and we will start shortly. Thank you. Good afternoon, good morning, and good evening to everyone. We welcome you all, particularly those of you joining from far away or at late or early times. Thank you for joining this WHO EPI-WIN webinar, The Utility of Pathogen Genomics Spotlight TB. For those new to EPI-WIN, this is the WHO Information Network for Epidemics for Science and Knowledge Translation in Health Emergencies. Our goal is to translate science in accessible, understandable, and relevant ways for evidence-informed actions and decisions in health emergency preparedness and response. Today, we have a great panel of experts to discuss the utility of pathogen genomics, Spotlight TB. My name is Lester, and I will be hosting today's webinar. To give a quick overview, you can find the topics and the speakers today. We will start with Dr. Tim Dahlman from Emerging Pathogen Intelligence Platforms in WHO Geneva, who will be giving opening remarks. And then we will have Dr. Patricia Hall Edison from WHO Global Tuberculosis Program. She'll be giving a talk on TB prevention, diagnosis, treatment, care, and innovation. And then we will hear two experiences from countries on research, implementation, and other experiences. So we will have Dr. Anita Suresh, Deputy Director of Genomics and Sequencing from FIND. And we will also hear from Dr. Shahid Valley Omar from Center for Tuberculosis, National Institute for Communicable Diseases in South Africa. So they will be both talking about second treat for drug-resistant TB surveillance and clinical use, and also the experience from South Africa, DRTB sequencing as a use case for pathogen surveillance and clinical management. And then we will have questions and answers. This will be moderated by the team, including Greg Armstrong from Task Force for Global Health, Caxton Moreira, Program Lead for Clinical Trials and Research, Research Community Science for Africa Foundation. And then we will hear closing from Dr. Josefina Campos, Unit Head for Emerging Pathogen Intelligence Platform. So that will be our special program for today. Before we proceed, here are some housekeeping and reminders. This webinar is currently being live streamed on the EPI-WIN YouTube channel, so you can also refer to that. The webinar is being recorded, and afterwards, the recording will be available from our website, and the address will appear in the chat. We invite you all to post your name, location, and organization in the chat box. And we see already a lot of names, of introductions in the chat box. So we love to hear where you're joining us from. We will have interpreters for Spanish and French. So you can find the interpreters interpretation tab in the Zoom screen in the bottom part if you need Spanish and French. Please add any questions you may have to the Q&A box. You can also find it in the tab in the lower part, and not in the chat, so we can easily keep track of them. And all comments, please keep these relevant to the topic and also positive. Please avoid negative, rude, or disruptive comments. For negative or disruptive comments, we will remove you from our webinar. So without further ado, let us hear the opening remarks from Dr. Tim Dahlman. Dr. Tim, over to you.
Thanks, Lester, and thank you for joining this edition of the EPI-WIN Pathogen Genomics webinar series, co-hosted by EPI-WIN, the Science for Africa Foundation, and the Task Force for Global Health. So the International Pathogen Surveillance Network, or IPSN, is a global network of pathogen genomic actors brought together by the WHO Hub for Pandemic and Epidemic Intelligence in Berlin as part of the WHO Health Emergencies Programme. Its vision is a world where every country has equitable access to sustained capacity for genomic sequencing and analytics as part of its public health surveillance system. And it functions to create a mutually supportive network that amplifies the work of its members to accelerate progress in pathogen genomics, improve access and equity, and ultimately contribute to improved public health decision-making. To support country capacity building activities, this webinar series aims to provide a forum for expert discussions on how pathogen genomics is being used in public health and clinical healthcare settings, and to review the evidence base for its utility in supporting decision-making and informing policy. Today's webinar will spotlight the utility of genomics for surveillance and clinical management of tuberculosis as the leading cause of death from any single infectious pathogen worldwide, and its role as a foundational capacity for building and sustaining cross-purpose genomic surveillance in many settings. Today's speakers will present current and future perspectives on the applicability of genomics to drug-resistant TB sequencing across a range of settings for emerging and circulating pathogen surveillance and clinical case management, exploring important topics including recent innovations in sequencing approaches, implementation models, and intelligence sharing. With that, I'd like to introduce our first speaker, Dr. Prisha Hall-Edison, who leads the diagnostic team at WHO in the global program on tuberculosis and lung health. Patricia applies over 20 years of scientific research, project management, and global laboratory capacity building experience to oversee development of global policy and operational guidelines for TB testing, establish and strengthen partnerships that further TB testing programs around the world, and shape the TB research and innovation agenda toward needed advances in test development, evaluation, and uptake by WHO member states. Through these efforts, Patricia and her diagnostics team aim to support universal patient access to testing services for patient-centered care and cure. Over to you, Patricia, if you'd like to start sharing your screen.
Thank you very much, Tim. Thank you to the organizers for the opportunity to present today. Good morning, good afternoon, good evening, everyone. It's my pleasure to present to you our WHO perspectives and resources on drug-resistant TB sequencing. So for those that may be less familiar, TB is an airborne disease that's caused by a bacteria, Mycobacterium tuberculosis. When an individual inhales small respiratory droplets that contain Mycobacterium tuberculosis bacteria, primary infection can be established within the lungs. In a healthy individual, this can be contained within a granuloma, and people can go on to live healthy lives with latent TB infection. However, in approximately 5 to 10% of individuals, they will progress to uncontrolled or TB disease, at which point individuals can begin to experience symptoms. They then become infectious to others. And this is often the point that individuals are eligible for screening based detection of TB, where all individuals who screen positive should have access to TB diagnostics that are WHO recommended, and all of those that test positive for disease should then be tested for drug-resistant TB. The results of these tests are then used to guide selection of appropriate TB and drug-resistant TB treatment regimens, where a multi-drug regimen is used because this bacteria grows so slowly that it's at increased risk of selection for resistance, and the use of multiple drugs with different mechanisms of action then can shorten overall durations of treatment, which are already quite long for tuberculosis. However, despite our knowledge of the disease, the long history, and the availability of tools, in our recent WHO Global TB report, it was estimated that approximately a quarter of the world's population had been infected with tuberculosis. In 2023, there were an estimated 10.8 million incident or new cases, and an unfortunate 1.25 million deaths, making tuberculosis the leading cause of infectious death globally. Of the incident cases, approximately 1.5 million of them were drug-resistant. Unfortunately, less than 50% of these estimated cases were diagnosed and notified to WHO by member states, and we recognize that there continue to be gaps in patient access to drug susceptibility testing services that are urgently needed, where only approximately 79% of the individuals that were confirmed by a test to have tuberculosis were tested for rifampicin resistance. Among those, only 55% were tested for fluoroquinolone and additional drug resistance. And we globally see very low rates of resistance testing to newly introduced TB drugs. And we do have advances in TB treatment, but that both shorten duration and are more tolerable for patients. These have been consolidated in the recently released WHO Consolidated Guidelines on Tuberculosis, shown here on the left, where this table shows that the type of disease that an individual experiences guides the regimen and therefore the drug combination that they receive in order to treat and ideally lead to cure. What you can see in this table is that in the top half, many of the combinations of the drugs are shared or similar. However, in the bottom half, we have new and repurposed drugs that have been newly introduced and recommended by WHO to treat TB. And altogether, this represents a wide range of antibiotics for which our tests are then challenged to be developed in order to appropriately and accurately diagnose drug resistance. Along with our advances in TB treatment, we also at WHO are seeing an expanded landscape of diagnostics used to detect drug resistance. We currently have multiple different diagnostic classes, which are groups of products that share similar criteria and characteristics to detect resistance across the range of drugs that are used to treat the disease. For example, in the gray rows, we have our low, moderate, high complexity immunological tests that are largely PCR-based or line probe assays that can detect a smaller range of resistance, but resistance to some of the key first-line drugs in anywhere from 2 hours to 1 to 2 days. However, you can appreciate by the table that the blue row remains our gold standard for comprehensive resistance detection across the drugs that are used to treat the disease using liquid and solid culture-based DST or phenotypic DST. However, because Mycobacterium tuberculosis is such a slow-growing bacteria, oftentimes these tests do not produce results for at least 3 weeks, leading to several months, at which point a patient could have undergone treatment for a lengthy period of time. This is where we get to sequencing, which introduces new advantages for detection of drug-resistant TB, including whole genome and targeted sequencing, where they share similarly nearly as comprehensive result panels in shorter periods of time, with whole genome producing results in approximately 3 weeks or more, and with targeted next-generation sequencing now being an option that can produce comprehensive resistance results from a single primary patient sputum sample that is also adaptable and scalable as we learn more about the resistance mechanisms that are associated with the drugs that have been newly recommended to treat TB. And so when we take a look back at our WHO drug-resistant TB sequencing guidance, it really began in 2018 with the publication of a technical guide that outlined the use cases for next-generation sequencing for tuberculosis, as well as a technical manual that updated some of the concentrations for culture-based testing to be used as a reference. In 2021, WHO issued the first recommendation for use of next-generation sequencing for surveillance of drug-resistant TB, as well as the first global standardized catalog of mutations in Mycobacterium tuberculosis and their association with drug resistance that served as the first reference for research and development of new technologies, as well as standardized interpretation for when people detect a mutation, whether or not it's associated with resistance and at what confidence level. In 2022, this is where we saw the introduction of new drug-resistant TB treatment regimens, and this required us to consider updates to our testing program so that the new drugs could be tested for resistance. The following year, we issued a second edition of the Catalog of Mutations. This expanded the number of strains, the range of geographies that were represented globally in the dataset that underlies the catalog, and also some early data on resistance detection among those new and repurposed TB drugs. This is the same year that WHO issued the first recommendation for use of targeted next-generation sequencing for clinical management of patients, as well as an implementation manual specific to drug-resistant TB. Then more recently, in 2024 and 2025, just this year, we've issued new and updated consolidated guidelines on tuberculosis diagnosis and diagnostic testing that consolidate all of our recommendations around TB infection, diagnostic, and drug susceptibility testing, including some updated solutions that have improved or expanded performance across a wider range of drugs that were assessed just this January. As a collaborative document along with these guidelines, we also issue WHO operational handbooks. These consider key implementation and practical options for programs, and they include diagnostic algorithms on how to use the results that come out of sequencing for patient management, particularly looking at what happens and what types of decisions or investigative actions should be taken if there are differences between the targeted next-generation sequencing result and culture or other PCR-based methods. So what I'd like to highlight for you is that in our initial phase of WHO guidance issuance on genomic sequencing use for drug-resistant TB, it was focused on drug-resistant TB surveillance. And what this did was initially allow multiple high-burden settings, as well as some moderate and lower-burden settings, to build their capacity for NGS, their technical capacity, their experience, to test out models of within TB program implementation versus integrated implementation for drug-resistant TB detection that could benefit them through surveillance and additional information in advance of needing to use those results for clinical care of patients. And Shahid will speak later about the South African experience of using this type of phased implementation approach. In fact, by 2024, we saw that of 21 surveys, periodic TB drug-resistant surveys in various phases of implementation, 14 of them, or 74%, were using or plan to use next-generation sequencing locally or through a WHO supranational reference laboratory. Where by that same year, 22 of our 24 supranational reference laboratories had capacity for NGS in order to support either their own countries or their WHO networks for research, surveillance, or clinical testing purposes. In addition, Anita, who's speaking next in this webinar, will speak more about the development of our catalog of mutations and the essential role that this plays in making sure that we have standardized interpretation and resources that are evolving as we learn more about the science over time and the technology evolves. What I'd like to highlight here is we do have a WHO TB sequencing portal, and this is where individuals can go to look at the geospatial distribution of phenotypic and genotypic profiles by WHO region, search for TB mutations, biosample data, and also submit paired whole genome sequencing and culture-based drug susceptibility testing data to be a part of our analytics pipeline that will inform the next version of our mutations catalog, which is planned for release next year. In addition, I just want to highlight a couple of key considerations around our recommendations for clinical use. When we talk about clinical use of targeted next-generation sequencing for drug-resistant TB, what we're referring to is the use of massive parallel sequencing to detect resistance to TB drugs, starting from a process clinical sample and ending with an end-user report. So these are really full procedures. And that in analytics and the report is based on the interpretation of our catalog of mutations. You can see we have 3 reagent kits that are recommended within procedural procedures that Anita will speak through. And all of these were found to be cost-effective, depending on the setting and context, acceptable and implementable. They were also found to be accurate among people with bacteriologically confirmed for detection of resistance to first-line drugs among pulmonary TB cases, and accurate acceptable among those with bacteriologically confirmed TB that's resistant to rifampicin as the first drug we use. So now where are we going? And this is my final slide. Just to say that we are moving forward with WHO guidance and recommendations for expanded resistance testing, harnessing advances and incorporating technological updates through the issuance of new guidance, such as our updated mutations catalog, supporting practical use by issuing a new manual for clinical use, increasing the global knowledge base on use of this technology for drug-resistant TB by issuing an e-course that will be available on the WHO Academy this year, and ensuring evidence-based testing by assessing new and updated products that could be recommended by WHO and that will be pre-qualified in the future. We also anticipate increased sequencing use to guide clinical management of drug-resistant TB, cross-sharing of enablers and barriers from the countries that have implemented this to date, and a review of service delivery models that particularly consider integration and leveraging existing sequencing capacity outside of the TB space. Lastly, negotiations for drug-resistant TB reagent and commodity pricing are underway, and we look forward to coordinated approaches that look at instrument procurement, maintenance as use as cost as a key consideration for these technologies against other available tests. Thank you very much.
Thank you, Patricia, for that excellent overview of the timeline that the next generation sequencing has kind of played against for TB surveillance and clinical management. And I think you can really show the kind of maturity of the technology over those years. And now I'm going to hand over to our next speaker, who's Anita Suresh, Dr. Anita Suresh, head of the Genomics and Sequencing Unit at FIND, whose work is focused on enabling genomic technologies and catalyzing country capacity for next-generation sequencing for drug-resistant tuberculosis, antimicrobial resistance, and pandemic preparedness. As the PI of the Seek and Treat grant, she led the evidence generation efforts resulting in the WHO policy on the use of sequencing for drug-resistant TB diagnosis. She's collaborated with national programs and global implementers on laboratory strengthening and tools for sequencing, and has 20 years of experience across the diagnostics value chain, including product development from concept to launch, technology assessment, clinical studies, grant development, R&D, and public policy. Over to you, Anita, if you'd like to share your screen. Thanks.
Thank you very much, Tim, and thank you to the organizers for having me. I'm also very happy to go after Patricia and before Shahid, because I think it's a very nice way to combine, and this good background, that the foundation that Patricia mentioned, that I can build off of here. So you've now already heard the background, sort of the evolution of how genomics, sort of the use case for genomics really in TB, and how it's come about, and how we are now at the stage with this policy. Where I'm going to take you is really a deeper dive into the clinical aspects of it. So really, what is that evidence needed to get to that policy, and really, how did we get there, and some of the details that Patricia mentioned, some of those specifics on how we went from there. So you've already seen that you've heard enough. I normally start with a lot of the stats on TB since it is so dire, the numbers, it is just striking for a disease that is completely treatable and curable. We still have such large numbers of people affected by it and such large number of fatalities every year. Nevertheless, it's very clear that there are newer drugs, there are shorter regimens now available for TB. So it is so important that we get people on the right treatment from the start. And so we really need to, in a way, think of protecting the drugs while we also protect as many people affected by TB as possible, which means we know with AMR, drug resistance is inevitable, but as long as you can stave it off in general by using judicious use of the antimicrobials of the antibiotic drugs here, that's what you want to be able to do, which means you need to have the diagnostics to go alongside the treatment. So targeted NGS is the focus that we started. So Seek and Treat is a project I'll be speaking on, where we really started this work several years ago. And the reason, of course, a lot of this was already described. Just to put that in a pictorial sense, we're talking about what the standard of care has been for TB, has really been started using culture. Now, liquid culture was already a big advancement over solid culture, which takes add a few more weeks to the 6 to 9 weeks at the time. The whole importance is that we always need to be seeing what is next. How can we leverage the latest innovations to benefit public health, to benefit global health, and diseases that are still plaguing most of the LMIC world. So this is where we see that now we do see whole genome sequencing, as we mentioned, already been used for surveillance. Now this for TB still requires culture because you need to grow up enough of the bug, but otherwise your sputum sample, which is typically the sample used here, is going to have too much of everything else, too much of the human, too much of other bacteria and so on. So you do need to grow it up in a sense to have enough of the DNA, be able to get enough DNA from TB to be able to do the sequencing. That's why targeted sequencing presents a nice in between. You still get as comprehensive because you know as many of the targets. As you saw, there's increasing knowledge. We know those specific targets within TB. We don't need to sequence the entire genome. At the same time, we can still get something that you can go directly from the clinical sample, which is critical when you're talking about something where you want to be able to get the diagnosis and the result to the patient, to the clinician, to be able to start them in the right treatment as soon as possible. So as the Seek and Treat, the work itself that we designed, so I'm going to walk you through very quickly on that evidence generation piece. That was a critical piece of what we were seeking to do. And this started really in 2019. So some of the pieces that Patricia mentioned, sort of this whole technical guide, which had the initial target product profile for sequencing for DRTB. This was the basis. Now, the basis was also some of these large-scale databases that existed that basically took the phenotypic and genotypic, essentially allowed us to say these mutations are associated with this resistance to these drugs. Now, these were as large a data sets as possible at that time, but still there was a need to pull them together to say, what is that list of truth? What is the smallest list or the most important list of mutations any test should have so that we can say we are actually truly getting to all the resistance and getting a clinically actionable result so that the patient can get the right treatment from the start. And so these were the basis that led to this, us being able to start on this project called Seek and Treat. The idea, as you can see, is really to be able to sequence to guide treatment eventually. And the first part of it was essentially generating the evidence, the analytical evidence, which means the lab evidence, just to say, does this test do what they say they do in the lab? And the next phase, the most important phase, of course, is that clinical evaluation. Do these tests perform as they say they do in the clinic itself, in the field settings, where the patient samples, where enrollment is happening in a prospective study? Now, in parallel, there was this whole aspect, as again, we described the whole idea of what is that knowledge base? What is that base as the foundation of data needed so that we can then, we can say that these tests cover all the mutations at a minimum that are known in the world today, that we can say with confidence are going to tell you about the resistance patterns in the sample tested. So these were both the bases, and the idea was to say both of these go to inform WHO policy on the use of TNGS solutions. And when it comes to something like sequencing, you don't want to stop right at just saying, okay, here's evidence, go ahead and roll it out. It is still a workflow. It's still a complex technology to some extent compared to your RDTs. So you definitely need to look at different NGS implementation models. Here's where I'm very glad we have Shahid. He'll speak a lot to this, where he's telling you in real time and in real life what this means in terms of what it takes to programmatically run this. So quickly on the clinical evaluation itself. So I said the analytical validation, the result was that essentially these solutions clearly demonstrated reproducibility and STIP calling accuracy, which means they accurately called what they say they cover. And when there is a mutation present, it is called. But that's the difference in a way between sequencing and PCR. If something is there, if there's a mutation that is there and can be sequenced, you will get the result. So there is at least that much you can be sure. And then the clinical study, this was a multi-center diagnostic accuracy study across India, Georgia, and South Africa, and really over 750 participants looking at references of phenotypic as well as whole genome sequencing that I pointed out as the other reference, the gold standard today at the time still being phenotypic. And really across looking at the accuracy for resistance across 13 anti-TB drugs. I saw from the list of participants and several of you from the TB field, so you would be familiar with these drugs, but you also saw from Patricia's earlier slide, they fall in the different categories. So what are deemed the first line, what are deemed sort of second line, but also those that are termed the new and repurposed drugs, which really are seen as that shorter regimens and so on. So all of these to make sure, can we get the answers? What is the sensitivity and specificity to each of these drugs? The two products evaluated, again, in our study that were then fed into that evidence for WHO, were one with the Genostring Illumina combination. The second was an Oxford Nanopore developed solution, which included the assay as well as the Nanopore sequencer itself. So you'll see very similar workflows, obviously different products used, really getting to the similar steps of extraction, target amplification, the library preparation, pulling the samples to actually do the sequencing, followed by the bioinformatics to get the results report out. So I don't have to go through all the data for you. You're welcome to now see the published publication online, which really talks about this evaluation of the culture-free targeted NGS for these two solutions, the data that fed into the catalog. So you'll also see the results essentially in the WHO guidance itself, the guidelines that talks about all the evidence synthesized for this and reviewed. But this paper really talks about this particular study because this was in a sense the largest data set or the largest study that fed into that review. I'll skip these in the interest of time, but I think, again, these are results you'll see that this is all the result of all of this. You'll see slightly different results in the two solutions, which is to be expected. But really what this resulted in, it was a policy, right? Essentially, this was evidence that resulted in policy on NGS for patient care across these two solutions. There was also a third solution, but there was data available and submitted to the WHO from Shunting called TB-seq. So I think this is more to tell you that the whole idea of evidence generation, the whole idea is it's a new class of technologies. We want to be able to see as many products as possible. I think this is with sequencing, you don't expect hundreds of players as you saw for COVID RDTs, for example, but you do want to see more than one company making a test, building a test for this. And that was heartening to see, and we see there are still companies building this, and that is very important in terms of an access perspective and in terms of availability across the world for an equitable access to these products. So again, we know, yes, there's evidence that led to policy, but there's still obviously a lot more to do, which is why we still have a lot of work cut out for us for the next several years, and I hope many of you on this call as well. So we said in terms of what are some of those challenges that we're still seeing, right? And then there's the idea of it is still acceptable, but can we make it easier? Can we make it faster? Can we make it easier to run itself? Can we make it less complex? So there's things I'll speak to from both aspects where there are efforts in place or there are at least tools being built to alleviate some of these challenges. So the first one, this is my chance to touch on this a little bit, is on translating mutations. So I did speak about mutations, the mutation catalog, and now that there's evidence for this. The thing is, we know that from sequencing, in this case, targeted sequencing, TNGS, it identifies mutations. But how do you know they're resistant, we need that clinical interpretation to be able to translate mutations into actionable clinical treatment decisions. As I said, for TB, we are blessed in a way to have a huge data set over several decades of data, and really over the last 5 years, especially intense sort of studies, trials, surveillance data, all of that fed into this whole knowledge base of what are those mutations, and when are we seeing which mutations alongside what phenotypically is resistant. I think that's the most important, that association of phenotypic and genotypic, what we are seeing in a sense from a clinical, what we can see physically in a culture test versus what is the mutations associated with that very same resistant strain. So I think the idea is, that not all mutations confer resistance. So how do we ensure then we are not saying every mutation do some action, but really these mutations are the most relevant. This means there is a problem. This means do not treat with this drug. This means you can go ahead and treat with this drug X. So I think that is the whole importance of this. So that accurate interpretation is really central to this care. And this was a whole sort of raison d'etre for the mutations catalog itself. So just more a very fundamental explanation of something that has now become a foundational tool, but it took a while to get to this place. As we said, now we are coming on version 3 of this catalog. So you can imagine such a catalog is not a one and done. It really needs to be something that's updated over time as more knowledge emerges, as unfortunately, as more drug rollout happens, as more treatment happens, more resistance emerges. And hence to be able to make sure we are tracking the diagnosis alongside any emerging resistance so that we are able to capture that as soon as possible and be able to get people treated again, put on the right treatment as soon as we can and prevent transmission of those resistant strains. So the difference in the catalogs, as we said, the idea was the increase in geographic coverage, the increase in the drugs coverage, and really powered by this whole knowledge base. But I'm having these here, hopefully you get access to these slides so you see the actual sheer volume of data needed. And there were several countries that have come forward. We are really grateful for countries that give, in a sense, surveillance data, but also other studies, sequencing data. And I know there are still more countries that you've seen that your data may not be represented here yet. We want to make sure it is. We want to make sure it is a global database that really captures everything and is useful for every single person, every single country. So this one, again, don't worry, but that is a lot of numbers. All I'm trying to show here is that compared to, what do I mean? Why do we need to keep improving or building new versions of this mutations catalog? So you'll see this, depending on data, I may not have found anything for pathogen, clofazimine, the newer repurposed drugs. When I did my first edition, which was 2020, 2021, we didn't have any data sets that were out in the field, but there were countries starting to roll out treatment in 2021 and 2022, 23, and so on. So because the rollout was happening, you could see there was already, you knew there was emerging resistance. I think countries were already warning us, they're unfortunately seeing resistance for these drugs emerge. And so that the goal was to say, okay, how quickly can we follow this up to add to this database, add in terms of the coverage, as I said. And so you can see already version 1 to version 2, from no data at all, pretty much zero, to nearly an 80% for clofazimine and a 74% for bedaquiline in terms of sensitivity. So this is sheer just the power of the data, knowing the data sets and being able to capture this itself. So imagine this then is the basis for new diagnostic tests. So your diagnostic test that probably had 0% sensitivity for these two drugs can, if you just make sure you're sequencing those targets, can suddenly show an increase in sensitivity just by making sure you have this bioinformatics, you have this database reflected in the assay. This is not relevant if you're not a product developer, but it is important that you're able to ask product developers you speak to, are they covering the latest and greatest mutations, especially as known in the catalog? Maybe they're going even beyond this, which is great. But at a minimum, I think now that the whole idea is it's a global good that these are the minimum set of mutations tests need to be covering. There are different ways product manufacturers can add to this. They can improve their bioinformatics. They might have to add to their PCR sometimes, but those are all sort of additional things as knowledge emerges to be able to improve tests. The beauty of sequencing, though, is you do not have to go back to the drawing board. It's perfectly scalable to be able to add new targets, add new mutations, additional ones that in the past you just sequenced, didn't do anything. You found a mutation, but the algorithm didn't report on it because there was no evidence to say why I should call it. But now I have it, and then I can make sure I call that, hey, I see a mutation in this gene target. Make sure you call it out, make sure it is reported so that the clinician can act accordingly. And from there, I'll go on. I think the tools, as we said, some of these were already mentioned. I do want to highlight the genomics costing tool because it's something we're working with the IPS and a lot of the partners, the country partners, and the WHO, Euro, and APHL, and several others in the UK HSA. This is an important one where now we are including TB in there. And as I said, other than the catalog, there's a lot of, as I said, improvements that are needed. And I think that's the part, a little bit what I want to say, that increased level of automation is one aspect. On the other hand, why do we need more automation? Can we make it simplified? Can we make the extraction and the library prep combined? So these are all various actual pieces of work that are going on, either funded work, funded research, or actual companies working on these. So there's sort of a sprinkling for you of what is coming, and that there's still more work to be done from an industry perspective, from an implementer perspective, from clinician and the country perspective on what you want to be seeing and what you need to be advocating to see to help your TB program. And that's a good part for me to hand on to Shahid, who will actually tell you what is going on at the country level in South Africa. Thank you.
Thank you, Anita. Yeah, a fabulous arc, evidence to policy to implementation, the refinement needed to ensure its internal quality and improvement, and the global goods of things like mutation catalogs. So I think really comprehensive presentation. So with that, I think we'll now introduce our final speaker, Dr. Shahid Vali Omar. Dr. Omar is a medical scientist with specialization in microbiology, focusing on mycobacterium tuberculosis research since his postgraduate training. He currently leads the Center for Tuberculosis at the National Institute for Communicable Diseases in Johannesburg, South Africa, which incorporates both the national and WHO supranational TB reference laboratory. His work focuses on diagnostic evaluations for both active and latent disease state, drug resistance determination and surveillance, molecular epidemiology of drug-resistant TB, and the application of novel technologies for these purposes. His collaborations are both local and international, and he's currently a principal investigator on several studies contributing to the development of novel strategies for the diagnosis of tuberculosis and drug-resistant detection and control of the burden of disease. Over to you, Shahid.
Thank you so much, Tim. Good morning, afternoon, and evening, colleagues, and thank you for inviting me to this presentation to the organizers. So I'm going to build on to what Patricia has already laid as the foundation. Anita has built up to where we're at currently with next generation sequencing for tuberculosis. And we'll just give you some use cases of how we've applied this technology in our environment for surveillance, particularly looking at continuous and district-based surveillance for drug-resistant TB in South Africa. So let me give you a bit of background to our journey with NGS. So we started off in 2012 exploring the application of NGS for drug-resistant detection. We then in 2013 established capacity at the National TB Reference Laboratory, which is the Center for Tuberculosis, and in that year delivered 2,000 genomes to the WHO, which was part of a bigger project, a multi-country global project. In 2014, we then joined the Cryptic Consortium, which was driven out of Oxford University, where we were looking at the genotype-phenotype association. So basically looking at the markers of resistance that are associated with resistance within our environments. 2015, our first paper came out looking at the performance and looking at using this tool for the purpose of drug resistance detection. We then also participated in 2016 in a WHO-led multi-country evaluation looking at the application for particularly population-based TB resistance prediction surveillance. And this was the primary work looking at its utility for surveillance. 2019, again, we assessed, we then got funded by the US CDC, and at the time Patricia was based there and was our lead, supported the Atlanta office, let's go and do a deep dive and actually find the utility and how we apply this in the South African context. And like Anita mentioned, 2019, we came out with the first WHO catalog of mutations, and all the data we generated from 2012 to then was submitted to this catalog. So by then a lot of data had been generated to actually support and provide evidence for mutation or resistance predictors. And in 2022, we then also submitted a huge cohort, a set of genomes to support the second version of the WHO catalog of mutations. And the focus more for South Africa was bedaquiline, because it was the first drug that was introduced after 40 years, a really important drug in our program for DRTB management. And also there had been a lack of diagnostic tools from its implementation. And South Africa has been using the drug for just over a decade now. So it was really critical to have this information. Just to give you an overview of the South African TB diagnostic network, right? So we built over we're close to 200 laboratories across the country. 173 of those are TB NAT or TB microscopy laboratories. We then have tier 2 laboratories that then perform 15 labs that do culture and DST. And then in the tier 3 laboratories, 6 of them highly specialized, where we perform genotypic DST as well as phenotypic DST. And more importantly, to the newer drugs, such as bedaquiline, predominant linezolid, and where the performance of genomic technologies are not, genome-based technologies are not really sufficient. And then we sit on the top as the reference laboratory in the country, and we have added an extra layer where we have been using NGS for some time now to actually support us where we have patients that are failing drug-resistant regimens and where phenotype is not really reliable. The maps below just gives you a distribution of all the laboratories in the country. I know one of the provinces are looking really, really empty, but that is the desert area of the country, so the population is really, really low, not much to service. But overall, in the country, at least close to 90% of the population live within a 10-kilometer radius to a facility that provides diagnostic testing that comes into our network. And then I think it is, I think it was, and then about 87% within a 5-kilometer radius. So with the introduction of next generation technologies, there was an article early in 2012 informing and actually looking at what this meant to, how will this impact clinical laboratories in the future. And next generation sequencing was really offering more than just detecting drug resistance. It could also be used for molecular epidemiology. So the traditional tools that we use that were time consuming and really laborious would be optimized by the use of this technology. And just in a nutshell, for tuberculosis, it's the bottom part of this figure. We were looking from generally we were looking at 1 to 3 weeks for detection using culture-based methods, and then to do all the drug resistance, the subtyping and typing would take an additional 3 months. However, with how sequencing would change this paradigm is that within 3 weeks we'd get our culture, and then within an additional day or two we'd be able to do all the rest that would essentially take us 3 months. So this was really, really the vision of what it would do to a clinical microbiology laboratory, and we're starting to realize this now a decade later. During that period, we started realizing the shift, right? A lot of work went into building the mutation catalog, and a lot of work has been supported by South Africa, where we actually, as early as 2012, started looking at using this tool for drug resistance detection. And we've been continuing on that path for the longest of time. And also at the same time, looking at it from a surveillance perspective. How could we apply this technology? How can it inform what is currently happening within our environment in terms of the spread and transmission of XDR tuberculosis? We also looked at a lot more than just extensively drug-resistant TB and building on the data that we currently have. So essentially showing that this tool is really powerful and could actually give us more information than just drug resistance, but also give us a bit more insights into transmission dynamics within our environment. This is really, so this is something that was really important for the country at the time. So new drugs were coming through the pipeline after 40 years. And South Africa had to be prepared on how we're going to manage the implementation of this. And this became part of the policy framework to actually initiate surveillance for new drugs that are implemented into our program. And this was really critical at the time because no recommended diagnostics were available. So we had to start looking at this at a very basic a microbiological level, looking at changes in minimum inhibitor concentrations in the lab, as well as at the same time trying to apply some of the whole sequencing work to try and understand what is resistance for bedaquiline. After we published our first piece of surveillance that took place between 2015 and 2019. This was after implementation of the policy framework. And what we actually found was at least 3.8% of people on the new drug already had resistance at baseline. A little bit concerning because microbiologically, anything above 5% is really concerning. And this is a new drug and a drug that we don't want to lose as fast as we've implemented it. What was really interesting was that most of the drug resistance that we identified were generally associated with acquisition rather than transmission. And then we also found some really interesting hits on genomics, genomic targets associated with resistance. And within our context found that a specific gene was the sole basis for genetic for resistance within our country. So this is just to give you a bit. So we were able to do some primary work looking at resistance surveillance and the application of whole genome sequencing or next generation sequencing for surveillance and also resistance detection. And then we started building on this and started looking at the application of NGS to strengthen surveillance of drug resistance in South Africa. So the key and important objectives of the study was to look at how can we can use it as an ongoing surveillance system to compare resistance profiles and to demonstrate how it supports and strengthens surveillance, particularly looking at drug resistance and early detection of emergence of resistance. Also in terms of phylogenetics, what are the transmission dynamics? How is the bugs being spread within communities? And then also looking at the longitudinal assessment. So basically ongoing surveillance and how can it assist us in supporting early detection of high-risk drug resistance. So this is an ongoing activity. We're currently at the end stage of sample collection and now started doing some of the final analysis for this component, for this activity. Well, what was really important is as we were going through these activity, so it was really research-based, but we were also starting to interrogate the data, looking most deeply into the data. And as we were going through the years, we started picking up some signals. So just to give you a little context, so initially we started focusing on MDR-TB because the technology is really costly. So we had to be really particular about what we wanted to sequence based on the money was available for us. And then it only made sense at the later stage that since the drug bedaquiline was being used for all patients that are rifampicin resistant, it would be important to include all of them into this. And unfortunately, there was funding that was given to actually support the activity to that level. So we focused primarily on 2 districts within the country, and these districts is currently going to inform how we move forward as a country. So we chose 2 metros. So it was the city of Johannesburg, our commercial district, and the city of Cape Town, which is also a dense and also high burden district in the country. And what we started seeing as we were working through the data, that we've seen a steady emergence of resistance within the environments. So just again, we should be careful on how we interpret these slopes, because here we were primarily focusing on MDR-TB, and here we're looking at all R-TB. So basically, any as soon as we pick up resistance to rifampicin, it would then be included into the work. And as we can see, like as time was going on, within years, we actually seen steady inclines in these slopes, and these were becoming really concerning. And then when we did the phylogenetic analysis, we actually started picking up growing, increasing size clusters, meaning that there seemed to be a lot of transmission within these environments, particularly in District 1. And then when we looked at District 2, we started seeing patterns where we started seeing emergence or expanding clones within an environment. And the important thing that can come out of this information is that we can also be a bit more targeted as to where we approach. So one of the objectives of the study is to actually take the data and integrate it with other data sources to give a more comprehensive view of exactly what is happening within our environment. This actually sparked and triggered a national review of what is happening with bedaquiline in our country. And we actually started doing we took the national data for all routine services and did a in-depth analysis on where we are in terms of bedaquiline and how is it, what is happening with the drug in our environment. And what we've seen is that, remember, prior to in South Africa, we only started doing surveillance in 2021 on all R. And for the country itself, we only started doing routine testing for bedaquiline for all RF-R patients in 2023. So the expectation was that as we see an increase in the number of tests being performed within the country, which we saw rapidly increase, we would expect a decrease in the resistance level, but we saw it quite stable and actually a little bit of uptick. And this was really concerning for us. And then at the end of this analysis, we found a bedaquiline resistance rate of about 6.5%. Remember, in the earlier the earlier analysis, we saw it somewhere at around 3.8%, so almost doubled. And 65% of those with bedaquiline resistance were fluoroquinolone susceptible, essentially meaning it was a good move for the country to actually move from all from a MDR pre-XDR only to a all R, because this had really important consequences that patients were acquiring bedaquiline resistance faster than fluoroquinolone. And from this national analysis, we actually picked up that 56% of patients had no prior exposure to the drug. That means that could be inferred from there that it is not acquisition anymore. Now it's transmission. So there was seeding in communities and drug-resistant bedaquiline was being spread. And this aligns very closely to what we were seeing in terms of the signals from our genomic analysis. This then sparked a national plan to address emerging bedaquiline resistance. We then held a national symposium the day before World TB Day, because this was really important for us as a country to start addressing the issue. And part of the pillars to address this issue was actually to establish and implement targeted next-gen sequencing for faster results to bedaquiline particularly. And how this would change for the country is that it took us approximately 56 days to get a result for bedaquiline through our routine clinical services using traditional culture methods. And now with the implementation of targeted next-gen sequencing, this result could be available as fast as within 5 to 10 days. So it was really important so that we could put patients on the right management and also prevent further acquisition to newer drugs, such as predominant in our national regimen. In terms, I touched on this in the previous slide, and just to give you a proper overview of the enhanced surveillance that we have a vision for in terms of the country, is to take our routine lab surveillance data, take our TB registry data, our whole genome sequencing data, as well as geospatial data, and merge them into a data repository, where we will then develop the tools to actually look at the disease burden, how it's been, what is the patterns of resistance, and how we're performing in terms of controlling the emergence or further emergence of drug resistance, and also apply some modeling to see what would happen if what interventions we plan to use in the country. This is a few of the reports where we actually started seeing now, and this is also going to start. We're at the moment trying to integrate the whole genome sequencing data into this. This is just basically giving us hotspots and cold spots of where we're seeing the resistance within our environments and within the country, and right up to a sub-district level. So this is really becoming an important tool for the country. And I think once we apply the whole genome sequencing data over this, it would actually give us a bit more insights into how the organism is transmitted between individuals within the country. The additional outputs with all this work is, like I mentioned previously, is the incorporation, is the what you call it, the development of the mutation catalog, because as established next generation sequencing is as a tool, performance is really dependent on how much information we know about mutations associated with resistance to give us a accurate picture of the current situation within country. And then also one of the other outputs from all these sequencing activities from our center was actually supporting, providing data to support the WHO recommendations on next generation sequencing. So as for us as a country, the sequencing has shown significant value for tuberculosis, drug resistance detection, as well as surveillance. It gave us an early insight into the emergence of pedacquulin resistance, which has really triggered a national response to control it. We also now identifying potential transmission clusters where we can have directed interventions. This findings really underscore the critical role of NGS for future, not only restricted to tuberculosis, but I mean, any pathogen within our country that is endemic or becoming problematic, so that we can have timely interventions and develop targeted public health strategies to circumvent them. And there's a lot of value with the use of NGS, particularly in terms of turnaround time and speed. I mean, there's daily improvements. In the early days, we were dependent on a culture to get a whole genome sequence out for TB. And there's already technologies that are allowing us directly from a sputum sample to get whole genome sequencing information, which is really, really important. For us as a country, the costs are really a bit prohibitive to actually apply to a high endemic country such as South Africa with more than 200,000 cases. I'm only talking about our focus was particularly on drug-resistant TB, which is a fraction, around 5% of the TB in the country. To expand it further, we really look at new strategies, and one of the strategies we're looking at is sentinel surveillance. So thank you all for your attention and giving me the opportunity to give our country's experience with the technology.
Thank you, Shahid, and thanks to all of our speakers today for a really comprehensive overview of the evidence base for genomics to support the surveillance and clinical management of TB. I think really a compelling use case. We're nearly at time, and thank you for our speakers who have answered many of your questions in the chat. I'd like to give the opportunity to hand over to Greg Armstrong. If there is another question he would like to deliver to our panel in our last couple of minutes.
Yeah, I guess and we are very short on time here, but just a very quick question for I think for Patricia. I think all the speakers have made the case that targeted NGS right now is quite accurate. It's quite fast. I think what remains for it to be useful clinically is for the complexity to be low enough, which I think maybe it is at this point for some of these tests, and for the cost to come down. I guess the question is, what do you think it's going to take for these technologies to be useful elsewhere to replace culture-based drug susceptibility testing?
I can give a little bit early insights into that. So we've done some costing exercises in country, and looking at one of the key things we always excluded in terms of costing was energy consumption, and energy has really become a big thing in country. And what we found is that TNGS is currently looking to be far more cheaper than traditional phenotypic testing, looking at a holistic overview of infrastructure, personnel, time to result, and everything else that's required. But the caveat is that for us to do surveillance, we might need more than just targeted next-gen sequencing. We need whole genome sequencing. And that is still relying on a culture component, which would then add an extra cost. But overall, it's looking comparable because we were just so used to accepting the current cost. But now there was one of the key, when we built the business case for implementation in country, we used this costing model to support. And as we're running through the first phase, we're already close to 300 patients in using the technology, we're actually realizing the value of this technology, not only in terms of cost, but also from a clinician's perspective, how much easier it becomes to managing patients. And now as we generate the data, we'll start looking at the utility of TNGS for surveillance purposes. Over.
And with that, I think we're already over time. Let me hand it over to Josefina.
Thanks, Greg, and thanks everyone for excellent presentations. I think it was an amazing webinar and a great use cases of how to use whole genome sequence. I will want to highlight the work from Patricia's team and WHO that has been working on this since 2018, as they mentioned, and they're moving forward to a third catalog for next year. I think a key highlights the importance of the interpretation on the data, and especially when technology is advancing so quickly. Have a full procedure end-to-end with a full report for interpretation. I think this is critical. Also on the next steps that we're highlighting and how to integrate this with other diseases as well, and the importance of the cost and how to reduce cost over time. Then thanks to Anita and the work they have been doing at FIND and highlighting this paradigm shift to have a strong correlation, be adaptable for the latest innovation, be scalable, and be faster. So I think this is critical, especially for the clinical use, but also for surveillance moving forward. How to move from policy to implementation. And we have an amazing presentation also from South Africa on how to translate this into national policies, especially when new drugs come to be in use, and also how this is also helping to understand dynamics. So congratulations to this great seminar and how to bring together the use of genomics in TB. Over to you, team, to the final. Yes.
Okay, thanks everyone. Thanks again to all of the speakers. I'll hand it back to Lester, just to, I think, for the final words from EPI-WIN.
Thank you so much, Tim, and thank you also, Josefina. Thanks to all the speakers for all the great discussions. We are finally at the end of our allotted time. I will wrap up by saying thank you very much to all our speakers and panelists today and the colleagues we have who have worked on this, and as well as the EPI-WIN team. We saw a lot of inquiries on certificates. EPI-WIN webinars were designed to provide updates and advocacy on critical areas on pandemic preparedness and response. And we hope that participants would join first to learn something new and understand how these new information can be applied in their settings. We used to provide certificates after participants have filled in the survey form after the webinar. We have had some delays in these in the past months and are currently evaluating how we can improve this. But big thanks again to the working team who supported the preparations for this webinar, including our colleagues from the WHO Emerging Pathogen Intelligence Platforms, FIND, NICD South Africa, Task Force for Global Health, and Science for Africa Foundation. Finally, we thank you all for coming and for your active participation through the Q&A. The recording of this webinar will be made available at the EPI-WIN website. An EPI-WIN digest and a slide set with the key messages on this topic will also be published shortly. If you want to keep updated for future EPI-WIN webinars, recordings, and presentations, please subscribe to our mailing list. The links are provided on the chat. And we hope you will join us for next webinars. The next one will be next Wednesday, July 9th at 1 o'clock. We have an exciting topic, managing the heat, strengthening public health preparedness for mass gatherings in a warming world. So we look forward to see you in the next webinar. Thank you all and goodbye. See you next time.